Think about these three questions. If I were to ask you, do you really trust politicians and the government? Do you really believe everything that you see or hear or read in the media? And do you believe everything that you see on the internet? I think if I were to ask anybody those questions in the world, they would say no. So what I'm saying is, look for yourself. The information is out there. You don't have to believe what people are telling you when you can go and look at the information for yourself, and that's the only thing I'm trying to ask people to do. I've got no objective. I don't make any money from this. I'm just trying to give people information. Hello, I'm Tony, and I'm an engineer, and I've been an engineer for over 36 years. And what engineers do is they use science to solve problems. You could call us applied scientists in some regard. Part of what we do in our job is we look at and analyze data. And what I've been doing since the start of this so-called pandemic is monitoring and looking at the data that's been publicly available in the UK from the government, the National Health Service and the Office of National Statistics. And what I'm going to talk about today is the actual facts as reported by the government, the NHS and the Office of National Statistics, and to show you what the truth is, but not what you're being told. So I'm going to go into what is a coronavirus case, and more importantly, what it's not. I'm also going to look at the actual data from the NHS on how many occupied beds there are. I'm going to reveal to you some shocking data about actual deaths that you've not heard before, I'm pretty sure of it. I'm going to go into have a look at how many real COVID-19 deaths are there. Have a little bit of a look at some of the information you're probably not hearing about vaccines, and in the end I'm going to summarize what I think about all of this information. So let's get started. So what is a coronavirus case? So PCR test is really molecular photocopying. PCR revolutionized the study of DNA to such an extent that its creator, Kerry B. Mullis, was actually awarded a Nobel Prize for Chemistry in 1993. The polymerase chain reaction, PCR, is a fast and inexpensive technique used to amplify or copy small segments of DNA because significant amounts of sampled DNA are necessary for molecular and genetic analysis. Studies of isolated pieces of DNA are nearly impossible without PCR amplification. So what is a PCR test used for? So once amplified, the DNA produced by PCR can be used in many different laboratory procedures. For example, mapping the human genome in the Genome Project. PCR is also valuable in a number of laboratory and clinical techniques, including DNA fingerprinting, detection of bacteria or viruses, particularly AIDS, and the diagnosis of genetic disorders. So how does PCR work? To amplify a segment of DNA using PCR, the sample is first heated so the DNA separates into two pieces of single-stranded DNA, or RNA. Next, an enzyme called a Taq polymerase synthesizes two new strands of DNA using the original strands as templates. This process results in the duplication of the original DNA, or RNA, with each of the new molecules containing one old and one new strand of DNA. This is known as one cycle of magnification. Then each of these strands can be used to create two new copies, and so on and so on. The cycle of synthesizing new DNA is repeated for as many as 30 or 40 cycles, leading to more than 1 billion exact copies of the original DNA segment. The entire cycling process of PCR is automated and can be completed in just a few hours. It is directed by a machine called a thermocycler, which is programmed to alter the temperature of the reaction every few minutes to allow DNA denaturing and synthesis. In an article in a British medical journal about using the PCR test for COVID-19 cases, it states, "Another problem with relying on PCR testing alone to define a COVID-19 case is that owing to the sensitivity of the test, it can pick up a single strand of viral RNA, but this doesn't necessarily equate to someone being infected or being infectious." In the datasheet provided by the manufacturers of the PCR test for the coronavirus, it states, "This product is intended for the detection of COVID-19 novel coronavirus. The detection of this result is only for clinical reference, and it should not be used as the only evidence for clinical diagnosis and treatment." The World Health Organization states that careful interpretation of weak positive results is needed. The cycle threshold needed to detect a virus is inversely proportional to the patient's viral load. So what this means is, the higher the number of cycles used to detect the coronavirus presence, the lower the actual virus load is in the person that the test is being carried out for. So in this article published last year, researchers deduced that patients with cycle threshold values greater than 34 do not excrete infectious viral particles and thus may be discharged into society. Basically, that means they are not infected with the coronavirus. So this person is writing to Public Health England mentioning that in the NHS document for doing a coronavirus test, it mentions that the protocol being used, it has cycle threshold of 45. So a Portuguese court has already ruled, in view of current scientific evidence, this test shows itself to be unable to determine beyond reasonable doubt that such positivity corresponds in fact to the infection of a person by the SARS-CoV-2 virus. And the judges also said that only a doctor can diagnose somebody with a disease. So now you know what information the government are giving you when they're telling you about the total number of cases or weekly cases or those things. A coronavirus case is not a medical diagnosis that a person has or had the coronavirus disease. It is not proof that a person is or has been infected with the virus, and it's not an indication that a person is an asymptomatic virus carrier that is spreading the virus. Okay, so now let's take a look at the actual NHS hospital bed occupancy levels. So if you go to the NHS website, you can actually look at the section called hospital activity, and you can download the spreadsheets for yourself. And I've taken a look at these for myself and had a look at the actual information. Now what you can see here in the blue line is the total number of beds that the NHS has at any one time or within that month or that 3 months that they can use. The orange line is the actual bed usage or occupied beds, and the red line at the bottom is the total unoccupied beds. And what is interesting here is I looked at the data provided by the NHS themselves since July 2015. And what you can see is a gradual decline over time in the blue line in the total number of beds available. But suddenly in March and June this year, we had a sudden drop in the actual number of beds that are available. And it still hasn't risen back to that total number that was there prior to the coronavirus coming. So I wonder why we suddenly had less beds. It might be because they were spacing them out more, but I don't really know. But more interestingly is that the total number of beds used has gone down drastically, and that the available beds that are left has risen. And if you look at the average bed occupancy between 2015 and 2020, and then compare that to the last year, what you'll see, for example, is in June, we were actually nearly 34,000 beds less than we normally are on a normal year in terms of occupied beds. In September, we were 16,500 beds lower than normal. In December, we were close to 10,000 beds lower than normal. And right now, we are at 20,000 beds lower than a normal year. So now let's take a look at the reports of the number of people occupying COVID beds. So interestingly, what you can see here is that the number of beds that were occupied by COVID patients in the grey line did rise up to the middle of January and then has been declining since. But interestingly, what you can see is that the blue line, which is patients that are occupying beds without COVID, right, has basically been the inverse of the COVID occupied beds. And you can see that by looking at this sort of orangey brown line that has basically been about the same the whole time, which basically means that as the number of COVID beds went up, the other beds went down, right? And we've basically been at the same level of occupancy the whole time. And therefore the NHS hasn't been under any undue stress. So you have to ask yourself, why did these COVID beds go up? Well, the reason is that if you're going into hospital for any reason at all, then you're going to be tested for PCR, using a PCR test when you go into the hospital, regardless of whether you're going in there with suspected COVID or not. And if you had a positive PCR test, you would then be a COVID patient. Even if you went into the hospital with a heart attack or a broken leg, you would still be considered a COVID patient. And as we know, the positive PCR test doesn't really mean that you've got COVID. So what this doesn't say is that loads of people went into hospital with COVID problems. What it really says is that the normal number of people are going into hospital and then they're being tested positive with a PCR test and therefore registered as a COVID patient. So now I'm going to show you what I believe is quite shocking information to do with the actual deaths that's been going on in the country. So let's take a look at that. So first of all, we're going to take a look at annual mortality rates. Here what you can see is the plot of mortality rates by season since the 1950s until 2018. And what you'll see is we've actually had a gradual decline over that time. If you go to the Office of National Statistics, you can download the age standardized mortality rates per 100,000 population. And what this does is it takes into account the ages and the size of the population and gives you a value which you can use to compare against different times in history. And what you'll see here is that the actual age standardized mortality rate has been going down progressively for the last 20 years. And you'll also see that every winter season we get a spike, and then every summer season it drops down. And what you can see here is in last year, March, April time, we did have a sudden spike, and that we also had quite a large spike in January. in 2021. So now when you look at excess deaths, let's take a look at this actual information now. So when you compare the excess deaths in 20 to 21 since the beginning of this coronavirus with the previous 10-year average all-cause deaths, what you can see is that we did have a big spike in April and May, and we've had another sort of rise in November, December and January this year. And you would think that that was to do with the coronavirus, wouldn't you? So we'll take a look. So when you compare the excess death data from the Office of National Statistics with the government's data on deaths within 28 days of a positive COVID-19 PCR test, this is what we get. In the orange and yellow colour, you see the coronavirus deaths. And in the blue colour, you see unexplained excess deaths. And as you can see, during the lockdown periods, we had massive increases in deaths compared to the last 20 years. So what is causing these extra unexplained deaths? Because these peaks in deaths were not because of the coronavirus. When you look at the government data for the deaths within 28 days of a positive PCR test for England and Wales, you can see on the 31st of January 2021, we had a total of 101,605 deaths. However, when you compare that to the Office of National Statistics information, you'll see that there's an additional 558,898 unexplained deaths. That's almost 560,000. Over 500,000 deaths that nobody is talking about in the mainstream media. And this is the shocking information that I think everybody should know about. Interestingly, in the second phase, the second lockdown, the rise in deaths corresponds with the first doses of the vaccine rollout. So when you get the information from the Office of National Statistics showing monthly mortality analysis, what is interesting is that in April and May, suddenly less people were dying in hospital compared to the seasonal average, and more people were either dying at home or in care homes. This suggests that people were avoiding going to hospital for treatment of serious conditions. So why were more people dying at home? This suggests that people were avoiding going to hospitals for treatment of serious conditions, probably because of two reasons: the fear of catching SARS-CoV-19 virus and the messaging of the government and mainstream media to save the NHS for treating the SARS-CoV-19 patients. What you can see from this chart is that there was actually a spike in hospital deaths as well during March and April. So why was this? So according to Dr. Klaus, and I can't pronounce his surname, a lot of these early deaths in hospitals were probably due to well-intentioned but ill-educated doctors giving dangerous doses of drugs to already weak patients. And some of these drugs were chloroquine, hydroxychloroquine, diodihydroxychloroquine, and azithromycin. There was a trial in Brazil that was halted early due to safety concerns, with the reason being stated that despite its limitations, infectious disease doctors and drug safety experts said that the study provided further evidence that chloroquine and hydroxychloroquine can pose significant harm to some patients, specifically the risk of fatal heart arrhythmias. A report published in the British Medical Journal, published on the 3rd of September 2020, titled "Suicide Rates Continue to Rise in England and Wales." It stated that the numbers of suicide deaths have to be interpreted with caution, because the pandemic meant that inquests were being delayed. It continued to say that given the length of time it takes to hold an inquest, which is around 5 months, we do not currently know the total number of suicides that occurred during the coronavirus pandemic. And according to another report, mental health issues due to lockdown and changes in financial circumstances has increased. So it seems that although the government and the mainstream media have been going on and on about the coronavirus deaths, there's actually been 5 times more, over 500,000 more deaths that nobody's talking about. And that's what I mean about the shocking data. So we have to ask the question, how many real COVID-19 deaths are there? We don't know. Let's take a look. So if you go to the National Health Service website, you can download the data concerning the deaths. And what you'll see, that most people that have died in NHS care that have had a positive COVID-19 death have died with pre-existing conditions. So I then went to the government website and downloaded the data to tell us how many people have died within 28 days of having a positive test. And when we take the data from the government website and apply the ratios from the NHS, assuming that it's the same ratio of deaths, what you can see is that nearly 96% of the people that have died with a pre-existing condition. And the majority of those are over 60. So when you compare the total number of positive PCR test cases with the number of people that have died within 28 days of having a positive test, just under 3% of the people that have had a positive PCR test have died within 28 days of the test. It doesn't mean that they died of coronavirus. It's more likely that they died of their pre-existing conditions. So we don't actually know how many people have actually died of the coronavirus itself. When you compare those numbers to the population, what you'll see is by far the 80 plus age group is the most affected. Interestingly, we are now putting all sorts of restrictions on school children and working age people that it's hardly affected at all. When you take a look at the breakdown of what the underlying conditions are, you'll find that they're nearly all metabolic function disorders. So when we take a look at all of these disorders, what you'll see is, like this one with diabetes, you'll see that the seriousness of diabetes increases with age. The same here for chronic kidney disease, the same here for dementia, the same here for Alzheimer's, the same here for a chronic obstructive pulmonary disease, and the same here for heart disease. So, are these people dying of coronavirus, or are they actually dying of other metabolic function issues? So, let's take a look at the vaccines. So vaccines have a yellow card system, which is reported by the government. And what we can see here, since the beginning of the vaccines, there has been almost 300,000 adverse reactions reported, with over 500 deaths reported. Of course, this is only the reported information. So some final notes. A case is a positive PCR test result, not a doctor's qualified diagnosis of a coronavirus. Doctors have not yet established the parameters to use for a positive diagnosis of coronavirus. The scientists have not yet identified the COVID-19 virus microbe. A PCR test does not indicate that a person is infected with the COVID-19 virus. The deaths associated with a positive PCR test do not mean that a person died from coronavirus. the huge spikes in all-cause mortality that were not related to people dying by COVID-19 may have been because of suicide, home deaths due to the stay-at-home messaging by the government, and maybe overdosing of patients during the initial outbreak of the virus. The total number of hospital beds was drastically reduced in early 2020. And since the outbreak of the virus, hospital bed occupancy has been unusually lower than the annual averages. Total available hospital beds do not seem to be any different than normal, and we do not ever seem to have been at risk of overfilling the hospital beds. And there is no evidence that supports a coronavirus epidemic in the UK at all. So why do the governments of the world seem so keen to inject everybody with a vaccine solution that is using technology that has never been approved for human use before, that would not complete its safety trials until at least 2022 and maybe even 2023? That is not a vaccine in the traditional sense of the term of vaccine, that has already had adverse effects, even with deaths, and the governments have given the companies complete immunity from prosecution when we do not seem to need a vaccine at all. And why are all the world's governments destroying their economies to make us take a vaccine? So, that's all I've got to say right now. Thanks. Goodbye.